Medical textbooks define stage 0 ductal carcinoma in situ, or DCIS, as a strictly localized malignancy. This diagnosis rests on a specific biological boundary. The malignant cells remain entirely confined within the basement membrane of the breast's pre-existing lactiferous ducts. This creates a clinical paradox. If a disease is truly confined within these ducts, it lacks the anatomical mechanism required to spread and cause fatal metastases in distant organs. Consider the case of a 57-year-old asymptomatic woman flagged during a routine screening mammography. Her initial presentation revealed a solitary, non-palpable tumor mass measuring 18 millimeters. A breast malignancy that successfully colonizes distant organs cannot be classified as in situ. The widespread adoption of screening mammography allowed physicians to detect sub-centimeter carcinomas long before they became palpable. While detection rates improved, vastly different underlying pathologies were clustered under the single umbrella term of DCIS. This mammogram displays the radiographic biomarker that isolates a highly fatal subgroup from true localized disease: fragmented casting-type calcifications. These calcifications map a branching architecture spreading deep within the breast tissue. Current clinical consensus views these extensive calcifications as a warning sign of high-grade disease, yet continues to categorize the process as strictly non-invasive. Categorizing this specific radiographic footprint as a stage 0 marker leads to inadequate surgical and oncologic care. Returning to the patient, the initial pathology report detailed an 80-millimeter region of grade 3 DCIS. Hidden within that span was a secondary finding: a small, poorly differentiated basal-like invasive carcinoma measuring 18 by 16 millimeters. The medical team noted a lack of metastases in the axillary lymph nodes at the time of diagnosis, providing false clinical reassurance. Driven by the in situ classification, the initial clinical response was conservative, consisting of 2 incomplete surgical resections. Localized treatment eventually escalated to a mastectomy, followed by standard chemotherapy. The patient then entered an apparent clinical remission during nearly 2 years of systemic tamoxifen therapy. The in situ label anchored the surgical team to a localized approach that was inadequate for the true scope of the disease. 24 months post-diagnosis, the patient developed multifocal liver metastases. Standard clinical logic assumed the small 18-millimeter invasive component was the only source of this distant spread. To confirm the cellular origin, physicians performed a core biopsy of the liver metastases. Positive immunochemical markers, specifically GATA3 and E-cadherin, confirmed the liver tumors originated from the primary breast cancer. The tissue structure in the liver completely mismatched the small basal-like primary component. Instead, the duct-forming structure colonizing the liver was identical to the tissue originally classified as non-invasive DCIS. The cellular structure universally labeled and treated as stage 0 was actually the hidden engine driving the fatal metastasis. The biological mechanism that resolves this contradiction is an invasive process known as Neoductgenesis. While true DCIS fills pre-existing ducts, Neoductgenesis aggressively bores into healthy stroma, actively constructing new, distorted tube-like structures. Fragmented casting-type calcifications mark the path of this invasive growth. These deposits are the necrotic byproduct left behind as the rapid construction of neoducts outpaces its own blood supply. These newly formed ducts exhibit a massive, disorganized architecture that infiltrates the surrounding stroma. These cancer cells are not confined by pre-existing anatomy. They are the architects of their own invasive network. Ductal carcinoma in situ is an inaccurate and dangerous label for malignancies presenting with fragmented casting calcifications. The in situ label suggests a localized threat, masking the aggressive biological behavior of this subtype. This specific subgroup requires reclassification as duct-forming invasive carcinoma, or neoductgenesis. Correct terminology aligns clinical expectations with the actual biological behavior of the disease. In oncology, accurate language determines whether a patient receives the treatment they need to survive. Maintaining the current diagnostic status quo results in the underdiagnosis of fatal breast cancers. This compromises surgical planning, leading to inaccurate calculations of the resection margins required to clear the disease. It also skews oncologic treatment protocols, denying high-risk patients aggressive systemic therapies at the earliest stages of detection. The 57-year-old patient's outcome is the ultimate cost of this anatomical misclassification. Radiologists, pathologists, and surgeons must recognize the radiographic footprint of neoductgenesis as a marker of aggressive invasion. Redefining this breast cancer subtype is now necessary to stop treating fatal invasive malignancies as stage 0 anomalies.